Hello, everyone. Welcome to the 16th International Symposium on MPS and Related Disease. We have had to live in a pandemic situation in which every event has been cancelled. We have planned a face-to-face symposium, and it is held every 2 years in different parts of the world. In 2016, Barcelona was approved as the venue for the 16th symposium at 2020. This symposium involved a great deal of work and preparation, and it was postponed to 2021 due to the pandemic. Given the uncertainty of the situation and with everyone's safety as a paramount priority, we finally to organize a 100% virtual symposium. Right now is the only MPS and related disease held virtually in full. We are very pleased to give everyone the opportunity to participate and be able to be present. It's a unique opportunity for families who have difficulties to move. In this way, they save traveling and can attend an event in which they will have the best and most up-to-date news on our diseases. I would like to thank the local committee, International Family Committee, MPS in the world, National and International Medical Committee, and Agora Events, of course, for working all together in this event. Thanks to the sponsors, because without them, it will be impossible to carry it out, as well as to the families and professionals from all over the world. I would like to make a special mention to all the MPS stars there in the sky, and also to family and friends who have let us due to COVID or other causes. All of them aiding us and give us strength. Enjoy the symposium. Finally, I would like to present to the Honorable Dr. Josep Maria Argimon, Health Conseller at the Catalan government, who has dedicated us a few words to welcome all of you to this event. Thank you. Doctor.
For their invitation to take part in this opening. I would also like to congratulate MPS Spain, the Symposium Organizing Committee, the Scientific Advisory Board, and the different MPS associations around the world for convening and organizing this meeting. Unfortunately, the pandemic we are currently experiencing prevents or makes it very difficult to hold face-to-face events. However, I am convinced that this virtual conference will be particularly enriching and beneficial for all participants. I have seen how the symposium program pursues different objectives, all of them of great value and use. Firstly, there is the scientific perspective, reviewing treatments, analyzing future treatment possibilities, updating clinical trials, etc. Then, there is the establishment of joint international networks that allows us to share initiatives that help to improve our approach to these pathologies. The symposium also includes aspects of a more healthcare-related nature, from a multidisciplinary perspective to help improve the quality of life of those affected. And finally, there is also a social aspect, particularly aimed at the children, young people, and adults affected, so that they can establish ties, share experiences, and feel they are not alone. I believe that this multifaceted approach is particularly appropriate for tackling the reality of this type of illnesses, and at the same time serves as a good example of how we should act in general in the field of health. Collaboration, teamwork, and the participation of all the stakeholders involved is essential in order to correctly respond to patients' needs. Government, professionals from different disciplines and levels of care, sectors across the board, health, social, education, labor, patients and families must work together in a coordinated manner, sharing information and points of view. In Catalonia, both the Rare Disease Program and the Rare Diseases Advisory Board work actively in this direction, working together with expert clinical professionals and patient associations. They also work with other government departments, such as the Departments of Education and Social Rights. Our model is based on a twofold approach: the vast expertise necessary to respond to these type diseases and community care, which must be adapted to the reality of each territory as much as possible. As you know, within the network of clinical expertise units, we work by thematic group, and mucopolysaccharidosis are among the hereditary metabolic diseases we deal with. The network resolution of these diseases was published in 2019. However, there is still a long way to go in terms of communication with the public and the resources available for coordinated action to be taken by the clinical expertise units with the areas, hospitals, primary care facilities, and the rest of the healthcare resources. In this sense, we have to focus on protocols so that the entire healthcare network is well aware of them and the necessary referrals can be made. That is why the coordinated multidisciplinary work led by the teams and the professionals involved is so very important. There is really nothing more I can add. I would just like to thank you all for your commitment to treating these diseases and related diseases. I encourage you to continue working along with this path of bettering people's lives and convey my affection to all those affected and their families. I thank you once again and wish you every success with this virtual conference.
Thank you very much, Honorable Josep Maria Argimon, for joining us on this special day. As President of the Scientific Committee, it's a great pleasure to welcome you to the 16th International Symposium of MPS and Related Disease. I would like to take this opportunity to send a very special and warm thank you to all my colleagues for their generosity in agreeing to participate in this Congress, to share their knowledge and wisdom, and to Agora for all their help in the organization. Having postponed this event for a year due to COVID-19 pandemic, it is even more valuable to have been able to gather all these incredible, talented, brilliant, and amazing professionals to present at this virtual event. This international symposium is normally held every 2 years in different countries, and we would have loved to greet you all last year our city here in Barcelona. However, we are very delighted to share with you the following 3 days, which will surely be full of opportunities to share knowledge and experience between the medical and scientific community together with the affected families. Over the next 3 days, we will be able to listen to top-notch speakers that will deliver 5 keynote lectures, over 60 presentations, and 40 oral communications. We have also received over 50 posters or more, which we'll be able to find at the auditorium, and you can also attend questions and answers sessions organized with the authors at the networking area. Do not miss out on the possibility to connect with healthcare professionals, scientists, families, and representatives from the pharmaceutical industry. Over 1,200 attendees from all over the world have gathered to share innovations, research, results, and information on MPS and related disease. We truly hope this meeting will help to promote research and knowledge at an international level to find better solutions to improve the patient's quality of life and support their families in the process. Quality of life today and tomorrow. That is our goal and the theme of this international symposiums, which we will hope you will enjoy. Without any further to say, please let me introduce you to the first speaker at the symposium, Professor Dr. Fritz Wickboom, from the Division of Pediatric Metabolic Disease at the Amsterdam University Medical Centers, who will share his expertise on newborn screening for MPS, where we are and where to go. Dr. Wickboom, it's a pleasure to have you with us. The stage is all yours.
Thank you. Thank you very much, Dr. Pineda, for this kind of introduction. I think, well, first I would like to thank the organizers for giving me the opportunity to engage with you during this symposium, to give this presentation. I think we all agree that everybody would have loved to come to Barcelona. It's a beautiful city in a beautiful, great country. So we have to postpone our travels to Barcelona, but it is as it is, and the COVID pandemic has changed the world tremendously. So we do it by Zoom. We do it through the computer. But I'm absolutely sure that the program will be great. I'm looking forward to the next couple of days. The topic of my presentation is about newborn screening, especially for the MPSs. And I would like to start with this little girl, Erin. She was born last April, so she is now only three plus months old. And in the Netherlands, we introduced mucopolysaccharidosis type 1, MPS 1, in newborn screening from the 1st of March this year. And 5 weeks later, Erin was born, and 10 days later, we got a result of the laboratory that Erin tested positive for MPS 1. So she is now a famous patient in the Netherlands and an important hallmark in the Netherlands for MPS in newborn screening. I will get back to Erin later during my presentation. Talking about newborn screening, I would like to start off with some historic notes. And I think a lot of medical doctors out there will know about Dr. Horst Bickel, a famous German pediatrician, who in 1951 discovered that treating a child with a metabolic disease called phenylketonuria, PKU, with a special diet restricted in the amino acid phenylalanine, really changed the behavior. This is Sheila at the age of 4 years before introducing the diet. So she has obviously a brain disease. And this is after starting the diet. So Dr. Bickel showed us that intervention in metabolic diseases could change dramatically the life of patients. However, this child was 4 years old when she was diagnosed and treated. And as a result, permanent brain damage had already occurred. So it became obvious that an early diagnosis, for instance by newborn screening, would be the best way to move forward. But that was difficult. And it took some time until the 60s, the early 60s, when newborn screening for PKU, this specific disease, became possible. And it was a lot of work. It was actually before my time as a medical doctor, but I know, and you see it on this paper, special gel has to be poured, an agar gel. It was done all by hand. And if this happened, it was a positive patient, and it was lots and lots of work, but it was a very sensitive way of diagnosis PKU. But lots of work and difficult to make a nationwide, worldwide newborn screening out of this. It was Dr. Robert Guthrie, American microbiologist, who discovered this newborn screening technique. And I think we can all acknowledge him as the founding father of newborn screening worldwide. It's interesting to see what happened. In the 60s, it was introduced in the USA. Later on, throughout Europe, all countries followed, but it took lots of years, like until 2019, until the last countries in Europe, Greater Europe, Eastern Europe, could participate in newborn screening for PKU. Lots of things, important things have changed over the years. While this was the way it was done in the 60s, nowadays, very different technologies based on big machines, expensive machines, MSMS machines, gas chromatography or whatever, have taken over all this manual labor, all this interpretation, allowing high throughput, meaning lots of samples being investigated in a short time and very sensitive and specific. And I think over the last 60 years, due to the technological advances by machines, but also the great steps forward made in treatment of inborn errors of metabolism, has allowed to introduce new disorders into the newborn screening panels. However, we have to realize, I have to click over here, we have to realize that if you look at this is 2016, if you look at what is the percentage of the newborns worldwide who are actually screened in a newborn screening, it's over 90% in the US, lots of Europe and Russia, Australia, Egypt, for instance. But there are many countries in which newborn screening reaches only a very small or none of the newborns. So there are lots of work to be done to allow newborn screening for all newborns worldwide. I told you that it's due to the great advances in newborn screening techniques, the big, beautiful machines, but also due to the introduction of novel therapies for inborn errors of metabolism, that a number of diseases included in the newborn screening panels have risen over the last decades. In 1974, in the Netherlands, we started with PKU, later with hyperthyroidism and adrenogenital syndrome. But over the last couple of years, there has been a rise in the number of disorders in the screening panel. And just as I explained to you, in 2021, it was introduced, MPS I was introduced in our screening panel. So why is MPS I included in newborn screening panel? It took some discussion in the Netherlands. It took long discussions in the Netherlands, but it was decided a couple of years ago that MPS I should go into the newborn screening. Why is this the case? Well, firstly, there is often a long diagnostic delay between the first symptoms of MPS I and the final diagnosis. And I will show to you on the next slides a study we did in the Netherlands on the age of diagnosis. And this is Hurler, so the neuronopathic MPS I, and the Hurler-Shea and Shea, the non-neuronopathic MPS I. Age at diagnosis of the Hurler patients is approximately, the median is approximately 12 months, and later, like many years, in the non-Hurler patients. If you look at the time in months between the visit to a specialist for signs and symptoms due to the MPS I and the final diagnosis, there is more than 6 months between the first visit to a specialist, medical specialist, and the diagnosis, and much longer, 2 years in the non-Hurler patients. So there is a long diagnostic delay. If you look at MPS III, Sanfilippo disease, it's even more striking. The average age of diagnosis is almost 5 years in the Netherlands. And if you look at the time in months between the visit to a medical specialist because of symptoms and the final diagnosis, it may take many months, many years before finally a diagnosis is made. And this is for the rapid progressing and the slow progressing phenotypes of MPS III. So there's a long diagnostic delay. We ask the question, did this diagnostic delay improve over time? And we hoped, of course, for a positive answer. But if you look at these graphs, this is the median age at diagnosis in the early 90s until recently. You see there is no, for MPS I and MPS III, there is only a small but not significant improvement in the diagnostic delay. So we have to conclude, and this is rather sad, I think, that all our awareness campaigns in which we try to convince all kinds of doctors that it's important to look at rare diseases, especially MPS in our case, did not result in a decrease in the time between complaints, signs and symptoms, and final diagnosis. This is called a diagnostic odyssey between first symptoms and final diagnosis. And this long diagnostic odyssey, which is, I showed you, is there for MPS I and MPS III, and which has not changed over the last decades, that really can be very harmful for both the patient and the family, going for unnecessary tests, going from one doctor to the other doctor to another doctor, and still not having any diagnosis. So important reasons why MPS I should go into a newborn screening is this diagnostic delay and the diagnostic delay being harmful for the child and the family. Another important issue is that an early diagnosis made by, for instance, newborn screening allows appropriate genetic counseling for the families and informed decision-making on future pregnancies. All these disorders are inherited disorders, and an early diagnosis is therefore important. And finally, of course, for MPS I, we know that early diagnosis allows for an early start of treatment, which improves the outcome of the disease significantly. On this slide, this is from our American colleagues. You see on the y-axis, this is developmental age, and this is calendar age. And normally when you have age 10, you have a developmental age of 10. If you have age 5, you are at a developmental age of 5. So the blue shaded area, that's normal. And what they did is they looked at the time of treatment for Hurler syndrome, the severe neuronopathic form of MPS I. In blue, these are early transplanted patients, 2 to 8 months. Yellow later, red after the age of 18 months. And what you can see on this slide is that the early treated, the early transplanted patients do significantly better than in red, the later transplanted patients. This makes sense because these are progressive disorders. So if there is a long time between symptoms and treatment, there will already be irreparable, irreversible damage done. So early intervention, early treatment is essential. So that's why we should do it. But there are also several challenges. For instance, we know there is quite a high number of false positive results for MPS I if you include it in a newborn screening panel. And this is largely due to what is called pseudo deficiencies, which mean the enzyme is low in activity in the screening. However, in the individual, there is not a disease. So it's a pseudo deficiency. It's not really there in vivo, in life. You can see this on this slide, publication by Lauren Clark quite recently. These are 4 states in the US with the results of MPS I by enzyme analysis only. And you can see that there are, for instance, in Missouri, there are 133 positive test results in 300,000 individuals screened. And of these 133, only 2 have really MPS 1. It's 1 out of 151 in Illinois. So the positive predictive value, so that means if the test is positive, what are the chances that the patient really has the disease, is absolutely low, and approximately only 1 out of every 50 positive screened newborns really had MPS 1. So this is not good because false positives are really not desirable in screen testing. So what can be done? If you look, this is for MPS 1. The enzyme is alpha-L-iduronidase, which is deficient in MPS 1. If you only measure the enzyme, you will have these false positives because of pseudodeficiency. And this is really the first step in screening. But if you introduce a second step in newborn screening, which is called the second tier, by measuring heparan sulfate and dermatan sulfate, which are the substrates of this enzyme, as a second step, you will see that if you have an individual with a pseudodeficiency, so a false positive in an enzyme screening, the concentrations of these substrates, heparan sulfate and dermatan sulfate, are completely normal. So by introducing this into the newborn screening, the number of false positives will be reduced dramatically. We have, as I said, only 1 positive screened patients in the Dutch newborn screening for MPS 1, and this patient really has MPS 1. So there is no false positive in our series up to now. This is largely due to work by Michael Gelb from the US, University of Washington in Seattle, who is really a wizard with all these metabolites, and this has improved screening for MPS 1 enormously. So this challenge can be overcome. Another challenge in MPS 1 screening is how to decide on the optimal therapy. So if you have a patient from newborn screening, 1 or 2 or 3 weeks of age, how can you decide on the optimal therapy? What is the phenotype of this patient? This is important because you know that there is a wide phenotypic spectrum in MPS 1, ranging from the severe neuronopathic hurler to the non-neuronopathic Shea phenotype. And the neuronopathic MPS 1 patients, they should go for early hematopoietic stem cell transplantations, while the Shea patients who will never have brain involvement will benefit from an early start of enzyme replacement therapy. So, of course, if you are, how can we know, for instance, in Erin, our first positive screened patient in the Netherlands, how can we know what phenotype? Will this be a Hurler phenotype or will this be a non-neuronopathic Shea phenotype? In the older patients with MPS 1, it's quite easy to see that this is a patient with probably a Hurler phenotype based on the facial dysmorphisms, based on skeletal involvement, based on umbilical hernia. But if you have very young newborns, it's much more difficult. And others have studied this, and there is already this in 2011, there is this beautiful publication by Raymond Wang and colleagues, Olaf Bodemer and lots of others from the US, who discussed in this publication, what should we do with this very early diagnosed pre-symptomatic individuals in case of a diagnosis very early in life by newborn screening. And quite recently, Lauren Clark and a lot of your others have published the best practices for diagnosis and management from the MPS 1 kids coming from newborn screening. And this is essential because you want to give the best therapy for each individual positive patient. So when we introduced MPS 1 in the Netherlands in our newborn screening, we made a kind of an algorithm. This is our Dutch algorithm. You cannot read it. This is by purpose. You should not read it because it's too complicated. but I can simplify it. And it's based, of course, on the publications by Raymond Wang and Lauren Clark. What we do, if we have a confirmed MPS I positive confirmed patient, first we look at the genotype of the patient. Very often in MPS I, and this is not for the other MPSs, I get back to that later on, in MPS I, very often the genotype determines the phenotype. So specific genetic mutations lead to a Hurler phenotype. But also clinical signs and symptoms can help. If the genotype is not conclusive, if it's a new mutation and you really are not sure is this a Hurler or a non-Hurler patient, early clinical signs and symptoms may help. And then you can decide, go for stem cell transplantation, or if it's a non-Hurler, go for enzyme therapy. But if this doesn't work, if the genotype is not clear and if the clinical signs and symptoms are not helpful, we have decided you should just wait and follow up a patient, see the patient every month in hospital and see how the clinical signs and symptoms develop. And then you can decide on what to do later on. Of course, this is a difficult part because you have to postpone the treatment maybe for many months, and you do not want to lose the window of opportunity for an early start of treatment. So there is discussion, can be discussion about that. So I think for MPS I, we can conclude that the challenges can be overcome in MPS I. And that is why we think MPS I could be safely introduced in newborn screening programs around the world. Yes, there are pseudodeficiencies, which may lead to a high number of false positives, but that can be overcome by looking at the substrate levels, heparan sulfate and dermatan sulfate in the same newborn blood spot. And we have algorithms in place which may detect the phenotype, so make a decision on the treatment at an early stage. But this is MPS I. If you look at MPS II, Hunter disease, things get much more complicated. Yes, there is a treatment available, enzyme replacement therapy. It is not that much compared to MPS I, which is now introduced in the US and in Italy and in the Netherlands and in Taiwan and in many other countries. For MPS II, as far as I know, there's only a few states in the US who have included MPS II in the newborn screening, and Taiwan has included MPS II in newborn screening. There are pseudodeficiencies. We know that from a very nice recent publication by Barbara Burton, who looked at the results of MPS II screening in the state of Illinois in the US. What to do with pseudodeficiencies, so false positives in MPS I? I think, and this is suggested in the publication by Burton and co-workers, that you may also look at the levels of heparan sulfate and dermatan sulfate. This is one of our Amsterdam publications, and we showed this is controls, MPS I, this is MPS II. This is in newborn blood spots. So this is a newborn blood spot of an MPS II patient, and we already see a very high level of heparan sulfate, but also of dermatan sulfate in the newborn blood spot. So the problem of pseudodeficiencies, high level of false positive, can probably be avoided like in the MPS I by looking at the substrate levels. Of course, one is really nothing, so much more work needs to be done. But this should not exclude MPS II or Hunter from newborn screening. But another problem is about the phenotype and the prediction and what to do. And this is because of if you look at patients with Hunter disease, this is from a recent study in Brazil. These are data from Brazil. Almost 75% of all patients do have this neuronopathic phenotype. The problem, though, is that if you should have a confirmed MPS II patients out of newborn screening, I think genotype and clinical signs and symptoms are not that helpful to decide on the phenotype. Why is this? Genotype is not really predictive in MPS I, and the clinical signs and symptoms are almost the same in the neuronopathic one as in the non-neuronopathic patients. We do know that enzyme replacement therapy does not treat the brain. So what can we do if you start to include Hunter disease in the newborn screening program? And if you have a positive patient, early, like 3 weeks old Hunter patient, what will be the best approach? And this is a difficult issue. So 75% will develop significant brain disease, and there is not an easy way to predict which patients get brain disease. Now we get to an ethical dilemma. At least in the Netherlands, this is regarded as an important ethical dilemma, for instance, for including MPS II in newborn screening. If you have to decide about a disorder to include in newborn screening, you can say yes, we should include MPS II and lots of other diseases, because we know, and probably you know, you as families especially, that all patients, all families will benefit from an early diagnosis and an early start of supportive treatment. You will shorten the diagnostic delay. You can go to a doctor who knows about the disease at an early age. In addition, and this is nowadays very important, that patients who are diagnosed early in life may benefit from participation in studies on new therapies like gene therapy for the brain or new enzyme replacement therapy. Furthermore, early diagnosis will always allow for genetic counseling and informed decision-making on future pregnancies. So you can say, what the heck, you should include all these MPSs in a newborn screening panel. But others may argue that newborn screening should be aimed at identification of disorders that can really be successfully treated, which means disease-modifying treatment and not supportive treatment, improving quality of life and decreasing morbidity and mortality. In the Netherlands, it was discussed that if you start to include untreatable disorders in newborn screening panels, this may lead to confusion and decreased participation in newborn screening. When we move on to MPS III, Sanfilippo disease, things get even more complicated. For instance, there is not yet, unfortunately, a treatment available for Sanfilippo. Lots of studies out there, but not yet an approved treatment. So it's almost nowhere included in newborn screening programs. And in addition, phenotype prediction can be difficult. Sanfilippo disease can be separated in more classical early presenting patients, but there are also late presenting patients. And our team from Amsterdam, together with colleagues from the UK, quite recently published a series of very late onset, so-called mild, but mild is always kind of a misnomer for this group of disorders, are now diagnosed, for instance, by genetic screening. These two ladies, for instance, over here, they were diagnosed late in their 50s, and they had a completely normal life until the age of 50 years. They drove car, they had a occupation, they were married, they have children, but they developed eye disease, retinopathy, and it was demonstrated, or cardiomyopathy, and it was demonstrated that this was due to a very late onset MPS III Sanfilippo. If you start to diagnose these very late onset patients by newborn screening, that poses a big problem, because you will have patients waiting for their disease. So you will have a 1-month-old baby who may develop disease when he or she is 50 years old, but can be completely healthy in between. And this can be a significant burden. So many people, at least in the Netherlands, have the opinion that late onset phenotypes should not be identified through newborn screening. But the issue, of course, is how can you be sure it's a late onset or an early onset patient? And one option might be to do genetic screening as a second step, reporting only those patients with early onset mutations. That sounds simple, but it's really not, because who are we to decide that the ones with a late onset should not be reported? That's a difficult issue, and you can debate on that a lot. So looking at the other MPSs, there are now some beautiful publications. This is from Taiwan, a very recent publication, in which they included MPS 4, MPS 6, and even Sanfilippo type 3B in a kind of a pilot study, looking at can we really have a good newborn screening test for these patients? And the answer is yes, you can test for these patients. You can pick them up by newborn screening. Of course, there are lots of work needs still to be done on the probability of pseudodeficiency, on phenotypic prediction, but it can be done. So getting to the final slides of my presentation, where are we and where should we go? Where we are, I think I have shown, and lots of others have shown through beautiful publications in the international medical literature, that MPS 1 can and should probably be successfully introduced in all newborn screening programs worldwide. Why? Because we have a good, we can do phenotypic prediction. We have good guidelines for diagnosis and management. There is a second step or second tier screening by measuring heparan and sulfate and dermatan sulfate in the newborn blood spots to decrease the number of false positives. And I am really convinced that screening for MPS 2, 3, 4A, and 6 is technically feasible. The Taiwan people, and this was work again together with Michael Gelb from Seattle, showing that yes, this can be tested, this can be done, though more work is needed. But where do we need to go? I think for MPS 2, 3, 4A, and 6, we need to be able to make an early prediction about neuronopathic versus non-neuronopathic, early onset versus late onset, rapid progression versus slow progression. And we need to decide what to do. Should we really make this distinction? Should we not report the late onsets? And this is essential to define the target population of your screening. Who do you want to screen? Do you want to screen all MPS 2 patients or all MPS 6 patients, or only the severe ones? Sorry. And then you have to decide on the optimal treatment strategy. Furthermore, I think important ethical discussions on the criteria for newborn screening is really important. And this needs to be done with healthcare authorities, those who decide on newborn screening, clinicians, scientists, and this should absolutely include patients and families because they know really about this disease. Ethical discussions, of course, the results of ethical discussions will be different throughout the world because, yes, we should learn together about the opportunities of newborn screening for MPSs, but we should also acknowledge cultural differences. When you discuss ethical implications, who to screen, how to report, I'm absolutely sure there will be differences between, for instance, the Netherlands and the US, or the Netherlands and Taiwan. And we should acknowledge that. Getting back to the Netherlands, ladies and gentlemen, my final slides. The Netherlands is so small that we need to enlarge it on the map to really see it. And in the Netherlands, I would like to get back to Erin. now 3 months old, or more than 3 months old. And I'll tell you her final story, because she was diagnosed with MPS 1 in April. Her genotype was not conclusive, actually. She had one known severe Hurler-type mutation, but the other mutation was novel and predicted to be severe, but it's prediction. So we did a thorough examination of Erin, and X-rays showed already quite a severe abnormality in the spinal column with a kyphosis. And we decided this is a classical Hurler patient. And she was transplanted successfully transplanted a couple of weeks ago, before the age of 3 months. And that is why I'm very happy with MPS 1 in the newborn screening in the Netherlands. 60 years made a lot of differences in technical issues on screening, but also in treatment. And with that slide, with this last slide, I would like to conclude my presentation. And thank you all out there. I don't see you, but I hope you see me, have seen me. And I'm open for any questions.
Thank you, Professor Wickberg. Your exposition is lovely. You have a lot of questions. There is one question that asked you if there is newborn screening for GM1 gangliosidosis.
That's a good question. I will be honest. I really don't know. I really don't know. Not as I know, it's not in the Netherlands, and I think if it's somewhere, it will only be in laboratory or first pilot studies. The issue, of course, is is there a highly successful treatment out there for GM1 gangliosidosis? Because a lot of countries worldwide will only include disorders in a newborn screening panel if there is a really successful treatment available. But I'm optimistic. I think over the next 1 decade, maybe 2 decades, lots of disorders, including GM1 gangliosidosis, will be included in newborn screening, but not now, as far as I know.
Thank you. My opinion is that I think the newborn screening, it depends on the countries, because, for example, in Portugal, they have a lot of MPS 6 and we have a lot of MPS 3. So I think that all the politicians also for newborn screening should take this in account. I think you think the same. I have you have a lot of questions. I have another question from Dr. Munzer. He asked, will all types of MPS 1 be detected by using second-tier gag measurements? And how much data do we have on attenuated MPS 1 newborn gag results?
I hope I understood the question good, but yes, you will. Of course, you will detect if you look at heparin and dermatan sulfate in a second tier. You may pick up other MPSs. I think that was the question. You will pick up at least MPS 2. You will pick up MPS 3. You will pick up MPS 6. Probably not MPS 4, but because it's a second tier, it's only done in patients in which the enzyme level of alpha iduronidase is very low. So there is an enzyme deficiency, and only in those patients we do in the Netherlands the second tier with heparin sulfate and dermatan sulfate in the blood spot. So I think the chances of picking up MPS 2 patient is really very small, because only after enzyme alpha iduronidase we move on. And I missed the second part of the question. I'm sorry.
Oh, wait, I look for it. He asked, how much data do we have on attenuated MPS 1 newborn results?
Yeah, and that's an excellent question by Dr. Munzer. We only a very, very, very few. So that makes it a bit tricky. We have measured in the Netherlands in a few patients, I think three or four, and we could detect without any doubt high levels of heparan sulfate and dermatan sulfate already in the newborn blood spot of these attenuated SHAE. They were all SHAE patients, but 2 or 3 is certainly not enough. So I think we will learn about this over the next couple of years. But the problem with which Dr. Munzer raises, that if you only refer patients with low enzyme and high dermatan heparan sulfate as a positive screen, you may miss the attenuated patients. I think it will not be the case, but I'm not completely sure. However, the screening in the Netherlands, at least, is decided to go for MPS 1 hurler, because it's absolutely clear that you should do a very early transplant in them. And it's considered that the less severe patients, the SHAE patients, will be picked up anyway. And there is a broader window of opportunity. But I think we will learn about this sensitivity of this heparan sulfate, dermatan sulfate on the attenuated patients over the next decades. So we have to wait.
You have another question from Zainab Al-Masari that says, what about including MPS 4 in newborn screening? Why we should include MPS 3, since still we don't have effective treatment and this is horribly progressive. Sorry. And this is a horribly slowly progressive disease.
I missed the 4. It was about MPS 4?
Yes, they asked, what about including MPS 4 in newborn screening, and why we should include MPS 3, since still we don't have effective treatment and this is a horribly slowly progressive disease.
Right. Well, I think first about the MPS 4, the 4A, Morquio disease, Morquio A. I think it has only been done now in one pilot study in Taiwan. It has shown that you can probably pick these patients up at an early age. I think basically you may say, okay, we have enzyme replacement therapy with Vimizim for Morquio A patients. And I think for all these patients, it will be true, though it's not proven yet. It's very difficult to prove, but it's really very logical that an early treatment with enzyme replacement therapy will work better than a late initiated treatment with enzyme replacement therapy. We know this, for instance, from sibling studies, which have been done, for instance, in MPS 1, in MPS 6, MPS 2. If you have 2 siblings and one is started on enzyme therapy at the age of 5 and the other at the age of 6 months, the one who started at the age of 6 months, they always do better. So I think you can make a case of newborn screening for MPS 4A as well, if you consider the treatment with enzyme replacement therapy with Vimizim as a successful treatment. For MPS 3, I think at this moment there is not a disease-modifying treatment. There are lots of trials on, for instance, gene therapy for MPS 3, but they have not reached conclusions yet. So there is not a treatment for all. So I think at least for the Netherlands, we will not include MPS 3 in a newborn screening panel only until there is a successful treatment. It can be a rapid progressing disease, although during the first 1.5 years, it seems to be more or less silent, but we know that once you make a diagnosis of Sanfilippo disease with a rapid progressing phenotype, which is the most frequent phenotype, there is already significant brain damage. And I think all the therapy in MPS 3 will be aimed at preventing brain damage, which is easier than which will be more successful if you do it earlier. So first the treatment, then newborn screening.
Thank you very much, Fritz. But we have to close. You have a lot more questions, but I hope they will do them in question and answers. Thank you. You have made us a lovely speech. Thank you very much.
It's my pleasure. Thank you very much.